Welcome to the next episode of Patient by Design, EpiSoft's podcast. And I'm joined today by our wonderful co-CEO and founder, Jenny O'Neill. Oh gosh, I've made a fool of myself. I've said your name. I feel like I should have let you say your own name. um, well, you know what? Let's pretend I didn't say that. And thank you so much for your time. Did you want to briefly introduce yourself?
Yes, sure. So I'm Jenny O'Neill, Chief Executive Officer and co-founder of EpiSoft.
All right.
So here to catch up with Jeremy.
Perfect. Yeah.
Can we do that
Bring-
again? Cut that bit out.
yeah. Cutting me into her myriad activities, bringing up the schedule. Also, it was just happy belated birthday again, Jenny. You just had your birthday,
Thank you.
and I hope that 22 is treating you well.
Yeah, a few decades difference, but that's all right. I'm not going to say.
Oh yeah.
What
Okay.
venerable age I have reached.
Yeah. And so, I mean, look, the reason why I thought it would be great, obviously, to have a conversation with you is just obviously one, to better understand and also help people understand why EpiSoft in the first place, what you and Michael's background was, what led you to, feel this was something necessary, something that you're obviously so passionate about and have recruited us, with your passion, for just improving outcomes in patient care. And given that, so kind of, I guess to start us off, your background is epidemiology, population health research. Is that right?
Yes, and health services research, which
And
is
health-
more the administrative side of research, seeing how health services are funded
Yeah.
and managed and planned for, so that as well.
Yeah, perfect. Yeah, and so obviously, and not, I guess the point is that not software, right? You and Michael were not initially software people.
No.
And so, of course, I'd love to hear just about how you feel that that's your specific background did shape, what you and Michael decided to build with EpiSoft.
Oh, sure. So quite a lot of people come into digital health from different backgrounds that aren't IT related. So it's more about looking at the problems in this health sector and how technology could solve those. So that's the approach that we took. And our background was really fundamental to how we developed and thought about the EpiSoft platform because, everybody wants to build quality software that fits in with healthcare providers' workflows that they use and value. But many systems have an underlying data model that doesn't really consider how data could be used down the track to analyse and hence improve health outcomes at a broader population health level. And at EpiSoft, we spent a lot of time on that part of the system, how it was structured behind the scenes.
Yeah. Jenny, I feel like this may be a bit of a stretch of a metaphor, but just because me, like, coming from like acting and productions and stuff, it's kind of said there that like the technical aspects are one thing. I think there's actually a Steven Spielberg quote. It's like, I'd rather have somebody who just on like the human level deeply understands the story than somebody who's this technical whiz master, etc. But I do feel like there is a parallel there, like with, what you and Michael have built, or I guess other, software health companies that are doing great work, where it is that human level and it's like a kind of different understanding that can create the best software that's most useful for the actual problems. And so,
yeah, and I think sort of in a way we might have been a bit unique in that regard from the population health and epidemiology background because we were thinking about macro problems and how software could, even though at the human level you've got to deliver on what people are seeing in their day-to-day activities and improving on that. But we did take a step back and say, okay, we want to solve that immediate business problem or clinical problem that people are experiencing, but how can we then just extrapolate that to a broader use case down the track?
Yeah, no, that's wonderful. All right. And, our listeners may or may not know that you spent several years at Merck, Sharp, and Dome beforehand working on the e-business development. And so I'm also curious, just, what that experience showed you about how the pharmaceutical world was thinking about patient information at the time.
Mm, mm. So we're in a fairly unique little business development group that was looking at the digital health marketplace that was relatively nascent in Australia at that time. There was obviously lots of doctors doing electronic prescribing and delivery of test results, and lots of the clinical components were there, particularly in general practice. But but digital health as a broad concept was more nascent. And so our challenge was to look at how we could either come up with ideas or back companies that had their own ideas that could help clinicians in their working lives and deliver better health outcomes, and not just, again, for the individuals, but from a more population health perspective. And so that was years before, the current explosion of digital health startups that
Yeah.
we see today. There was very,
Mhm.
very few kind of new small companies in the space. There were some established companies, and that was it. And so that was more than 20 years ago. And so I'm pleased that we did achieve quite a lot, because we see funded in some cases and designed in some cases technology that, and identified a technology partner that could deliver on that idea that we had. And some of those platforms that we helped design and or funded are in
Yeah.
use today. Yeah,
Yeah.
that was a long time ago. So that was over
Right.
20 years ago.
Well, no, I love to hear that. And I'm also curious, like, specifically, in the work environment that you were in, were there any specific ideas about how the data being collected could be used differently, more beneficially, that kind of particularly inspired you and Michael in those times?
Yeah, I mean, so one example was a software platform that plugged into general practice systems to have a look at patients that might be undertreated, overtreated, and specific conditions. So it was giving doctors access to a broader use of their data to look at,
Mhm.
trends in how their
Yeah.
patients are being treated, and to potentially more effectively treat them by improving the recall process or looking at patterns of how things worked. And that's definitely
Yeah.
translated into the EpiSoft platform as well, at the more
Yeah.
chronic disease, serious chronic illness, which is where we operate. But
Yeah.
in the earlier days, we were sort of looking at more on the general practice side and how we could help general practice.
Yeah. No, that's awesome. And what you said too about the overtreatment and undertreatment, it reminds me of Edward and I. And Edward is a colleague of ours at EpiSoft, or an underling in Jenny's case. No. But we had a really interesting conversation with this doctor from WA at HIC, and he
Mm-hmm.
was talking about how, in an emergency room, we oftentimes will look at a metric of, saving time and the wait, and that's a win.
Mm.
But he was saying that, like, but how many people are in the emergency room who don't need to be there, right? And they could have been
Mm.
treated another way,
Mm-hmm.
versus, somebody who is, let's say, that, I think the analogy he made was somebody with a mild pain
Mm-hmm.
that's sitting there for 6 hours is like magnitudes of order different than somebody who's, let's say, on death's door, or, much more severe, having to wait an hour or 90
Mm.
minutes. And just how do you kind of start to approach more nuance and things like that. And I mean, I definitely feel like what you're talking about is a big, I guess, positive, in that, in the realm of those kinds of things.
Mm.
um and Obviously, for a long time, hospital systems were being built around the admission, discharge, transfer, and billing, for
Mm-hmm.
many decades,
Mm-hmm.
with my limited understanding. Um, why is it that you suspect the sector has taken so long to move from kind of administrative infrastructure to more genuinely clinical systems?
Mm. Yeah, the challenge has always been a compelling business case, particularly in hospitals. So it's obvious that if you have a clinical software system that can improve connectivity of the care team, improve the legibility of documentation, reduce clinical errors by having proactive clinical decision support, then you are going to get better health outcomes for the patients in those hospitals. But the challenge has always been, how do you put a return on investment figure on that for a board that's got limited resources and has to figure out where they're going to go? And so that has been a challenge, but it's definitely turned around in the last 20 years, because when you mentioned HIC, when I was at the Health Informatics Conference like 20 years ago, everyone was talking about EMRs as the next holy grail, meaning no one had them really at the time,
Yeah.
a couple of hospitals. Now they're just ubiquitous, at least in the public sector, but what is challenging is that they're still relatively sparse in the private hospital sector, and the reason is exactly the same as 2 decades ago, that the
Hmm.
business case, putting a dollar figure on the business case is challenging. And
Hmm.
it's also a common misconception that private hospitals are totally devoid of EMRs. That's what people working in the public hospital system think, but it's not true. There's, a number of private hospitals do have EMRs, but a lot of them have also embraced EMRs in certain areas of the hospital and not necessarily had, an everything everywhere all at once system
Yeah. Yeah.
that operates across every single ward and every single department. But they do
Hmm.
have, I guess I'd say, electronic components of the medical record are digitised, not the whole thing. And so, examples would be endoscopy systems where they're taking photographs and reporting electronically on the endoscopy reports. Cardiac cath labs often have clinical systems, and in our area, infusion wards or departments that are delivering chemotherapy and other infusions do have more electronic medical record penetration in the private hospital sector
Yeah.
than they used to. Yeah.
Yeah. Okay. Yeah. I mean, so it seems like the challenge has always been and kind of continues to be, it's like, how do we avoid kind of areas of the hospital or areas of information being siloed and all these kind of disconnected? Yeah, no, I definitely, can
Yeah, and that's
understand that.
that. It just takes relatively hard yakka. Like, some things
Yeah.
plug in because there are standards where you can just plug something in and it just suddenly talks to something else. So that does happen these days. But the bigger challenge, I think, in interoperability is people just say, customers will often say, well, does your system integrate to this other platform?
Yeah.
Without actually saying why they want that to happen,
Yeah.
what business problem they're trying to solve with the interoperability, what actual business objectives they want to achieve from that integration. And that, I always pin customers down to say that,
Yeah.
yeah, we integrate, but what do you want to achieve by integration? It might be
Yeah.
something as simple as not rekeying the demographics. That's like 101 integration, but
Hmm.
often it's a lot more nuanced than that in terms of workflow integration, and it
Yeah.
takes a lot of hard yakka to actually make people think about what they want to achieve and
Yeah.
whether it's feasible in whatever time frame they have or whatever budget they have, and so on.
Yeah. No, that's crucial. I mean, it just makes me think of too, at HIC, just when Edward and I were having some chats with people, it's like, oh, kind of what have you been hearing and what's the overall, I guess, themes, I guess, and a bit tongue in cheek. We're like, oh, interoperability
Mm.
and integration, you know what I mean? And it's just like, obviously, generally people are aware of that, but I love what you're saying about, like, we need to get to the specifics.
Yeah,
Why are we doing exactly, what are we trying to do?
exactly.
Yeah.
Exactly. And it's
What's the
also,
roadmap?
they talk about it as if it's the holy grail, as if we haven't achieved it yet. But,
Yeah.
there's tens of thousands of systems in the healthcare sector that are interoperating and are
Hmm.
integrated very tightly. And so it's always, you can do more when you've got the time and the resources to do more. But to say
Hmm.
the system's not currently interoperable is, whoever's saying that doesn't know what they're talking about.
Yeah.
Um,
Yeah. Yeah.
we've
Um,
achieved a great deal in that area, but there's
yeah.
still more work to do, of course.
Yeah,
So,
of course.
yeah.
Okay. Yeah. And You know, this podcast does happen to be called Patient by Design.
Mhm.
I would love to hear, what does that phrase mean to you? And to what extent do you think our current health system has internalized it?
Hmm. Okay. Well, I guess most digital health platforms are for an audience other than patients. So
Hmm.
they focus around the needs of clinicians and administrative staff in clinics or hospitals.
Hmm.
But that doesn't mean they can't also embrace patient by design. So let's think of a few examples. So if you design a patient work list that tells you what the patients are there for and if they're in the waiting room. You could have comprehensive status tracking so patients don't get stuck in the waiting room. That's one of
Yeah.
the things that people actually said was an immediate benefit from implementing our system is they knew what they were there for and what they were waiting for. And there's also, another example. You design a patient flow chart that shows a summary of their last few visits. So the clinical staff can see at a glance how the patient's treatment or chronic disease is going, how it's progressing, any problems. So it doesn't necessarily mean just because you're building for a different audience that you can't build patient by design into everything you think about.
Yeah.
And we're also, as you know, Jeremy, in the space of building consumer portals that are directly patient facing,
Yeah.
and so that's our EpiMe or e-admissions platform, and that's all about making the steps the patient has to take to prepare for hospital as simple, as easy, as stress-free as possible, as much as you can be unstressed in having to go to hospital. And we're
Hmm.
constantly acting on feedback from patients who might find certain questions or system functions confusing. And the minute you get a few people saying the same thing, and it's more than n equals one having a problem with something, you've got a little systemic issue that you have to resolve, and you've got to get a new release out there that makes it easier for people. And so that's what
Yeah.
we do. We're always thinking about the patient as part of the design in
Yeah.
both examples, both of
Yeah.
our
Just
platforms.
yeah, just trying to streamline that. Is there is there any particular area when it comes to obviously like designing for, the well-being and ease of patients? Generally speaking, in Australian healthcare, is there any area that maybe hasn't moved as quickly as you hoped?
I think we're still lagging in systems that support patients with chronic disease. And the reason being is that they're all designed around patient goes to see a doctor, patient goes to hospital, they're out of there. So they're
Yeah.
all much more transactional around the immediate care that the patient needs then. So I think we haven't been as good at designing systems that support patients with chronic illness and the
Yeah.
clinicians that are treating those patients, whether it's in a public hospital outpatient department or a general practice clinic or
Yeah.
so on. And there's a lot of there's still a big hole there, I think, and the big hole is often that the most seriously chronically ill people are treated in public hospital outpatient departments. And
Mm.
again, very challenging to get a business case around a chronic disease platform for a specific specialty, where you may not have it's not a volume business, if that makes sense. So you've got a
Yeah.
small group of customers so
Hmm.
that's challenging. I think we
Yeah.
haven't really gone as far as I'd like us to go in that direction.
Yeah. No, I mean, I think that's even, obviously to the extent that, we work with chronic illness, like I understand that. But generally in the healthcare space, I have noticed in the past year how little I do hear talk about that,
Mm.
and so, it's just like a very refreshing answer to hear from you.
Yeah, and transfer of
um
care is still also a challenge, transfer between nursing home and hospital and back to nursing home.
mhm.
All those sorts of transfer of cares between different parts of the sector remains a challenge to make meaningfully interoperable, so that people's care is more seamless
Yeah.
between those parts of
Yeah.
the system.
Fantastic. And just, around that kind of seamless care, I know that, you and Michael spoke to and speak to a gap. between what clinical research knows about optimal cancer care and what actually gets translated to, what's happening at patients' bedsides.
Mm.
In your opinion, how much has that changed,
Mm.
over time? And how wide do you think the gap still is?
That's a good question. I think the gap's definitely closed over the years.
Hmm.
So the guidelines developers, so in our case, it's mainly the New South Wales Cancer Institute, and I say mainly because they cover all the guidelines for the best practice care for patients with cancer, but there's a lot of other patients treated in infusion centres that have other chronic illnesses. Anyway, so what we have done is so New South Wales Cancer Institute does a fantastic job of maintaining those guidelines, notifying of when updates occur, and we take those updates as soon as they come out and prepare the next version of the guideline, tell our customers it's there. And most of our sites have opted into our new way of automating the withdrawal of the old versions of the guidelines, which encourages the customer to publish and keep up with the latest best practice. So so we've definitely, in our small part,
Yeah.
contributed towards ensuring clinicians have the latest evidence at their fingertips. There's also evidence that using a platform like ours much more standardises care towards agreed best practice by having those New South Wales Cancer Institutes inbuilt and constantly maintained by us. So yeah, I think we've definitely helped close the gap. And yeah, there's always still more to do by
Yeah.
ensuring that customers you do use the latest version, which we always make available to them.
Yeah. Well, so look, please, correct me if I'm overstepping, but it sounds to me like with EpiSoft, there's virtually no gap.
No gap as far as between the New South Wales Cancer Institute
Yeah.
deciding what the latest treatment is and
Yeah.
that's now available to the clinicians. So no
Of
gap there.
course.
Yeah,
Yeah.
so
Yeah.
uh, yeah, we've definitely closed that gap.
No, no, it's amazing. And with EpiSoft, it was built on the idea, like as we're talking about, real world evidence flows from treatment, um, from the treatment front line to researchers who can then make sense of it. And so it's kind of, continuing that loop, I suppose.
Mm.
Um, what is everything that it actually takes to make that happen?
Mm. I can't tell you exactly because we haven't got there yet, other
Mm,
than that it takes a huge amount of resources,
mhm,
streamlined ethics approval processes, which are better than they were, but still not as streamlined as they could be, especially in the
mhm,
private sector. And the other challenge has been ensuring that the fields that are essential to tracking outcomes of care in a particular area of care are completed and updated routinely, because if you're saying what the treatments are happening but not saying how that's actually changing the outcome, then you've only got half the picture. And so I think AI will help to revolutionise how
mm,
researchers can make sense of data and potentially how we can surface outcomes data more effectively in our platform. I'm
mm,
excited about that future, and
yeah,
how AI can help that, but it still does take a lot of resources to make that happen. And
yeah,
again, you've got to make sure that you've got the business case clear and you're working with partners who know how to commercialise that data, because that's not us.
yeah.
Yeah.
Okay, yeah. It depends on, I suppose, the end users of EpiSoft.
Hmm.
Okay.
Mhm.
Yeah. Okay. Um, and you personally, you've been close to the Australian health IT industry for over 20 years. So since you were a ripe 2 years old, but including as president of the MSIA, um, when software companies are trying to build for complex clinical environments, are there any mistakes that you feel kind of repeat themselves or kind of tend to pop up more than others, or maybe
Mm.
even mindsets to solving these kinds of problems?
Yeah. Mistakes are common, but common mistakes are a bit trickier to to isolate, but
Mm-mm.
I mean,
That's
there's a
okay.
few common themes. It's one I mentioned before, which is where vendors claim they can integrate to XYZ
Oh.
and ABC platforms, but when it boils down to it, the integration isn't useful, or at best it's semi-useful, and so they leave out all the bits that really make systems connect meaningfully. So they
Hmm.
do the bare minimum to say they can integrate, but that's not always what delivers the benefits to the end users. What else have I seen? I've seen software companies claim to be fire capable, and
Ooh.
that's a big so what for me, because if like fire capable is one thing, but if someone tells a story about how they use fire to solve a business or workflow or interoperability problem, so the context is given and they can explain why fire was the right approach, which it is because it's the future of standards in interoperability in healthcare, but it's more useful to understand what they got out of it or what their end users or customers got out of it. That's a much more useful claim to make than to say, oh yeah, we do fire, so we're better than better than everyone else. That
Yeah.
really annoys me. You've got to,
Yeah.
yeah. I'd rather hear about what people are what software companies are doing to change things more meaningful at the coalface, meaning making healthcare more efficient, making clinicians more productive, improving health outcomes. That's a more
Yeah.
important story than we do fire. Yeah.
100%. Yeah, just kind of resisting the buzzwords, the
Yes.
kind of
Yeah.
trends of the moment. Yeah,
Yeah.
there was
That's
actually
flag.
yeah.
Buzzwords are red flags to me.
Yeah, there you go.
Mm.
There was an unnamed health let's say information session that I saw recently. And there was a genuine problem was raised, by this person. It's like, oh yeah, this is a problem affecting doctors. But then the conclusion was, and then here's how we made a bunch more money. And so it was like, wait, what happened? Like, it was like a bait and switch, and I was like, okay. I was like, well, those poor doctors are still dealing with that problem, aren't they?
Yeah.
Oh my gosh.
Happens
Okay.
where you solve a problem that's either not there, or
Yeah.
or
Yeah.
ignore the one that is there and solve something else that no one wants solved. So yeah, anyway.
Yeah. Okay. And so look, I know obviously, about the Cancer Evidence in Practice initiative.
Hmm.
Um, would you be able to, explain a bit more about exactly what it is, and the impact that you feel it's been able to make on patients over the years?
Hmm. So it was a big vision,
Yeah.
and I think we've achieved some of it. And so it's what we discussed before is taking data from the front line to inform future care. So having that available to researchers in, potentially near real time, so that future decisions of care can be made more effectively. So that's one part of it. And the other part is, of course, taking data from the researchers and
Hmm.
ensuring that the clinical teams that need that have access to it as quickly as possible. And I think we've achieved the latter, as we discussed before, but the
Hmm.
first part of that vision, I'm going to leave that to the next generation.
Yeah. And what does a hospital have to do to kind of contribute to this and be a part of this? Do they have to be EpiSoft customers, or i- are there people who are not necessarily customers that have relationships with you regarding that?
To contribute to the Cancer Evidence in Practice initiative, you mean?
Uh-huh. Yes.
Yes, I mean, well, yes, they are, ideally would be EpiSoft
Yeah.
customers. Then
Yeah.
at least we know how to surface their data and potentially we can use it to benchmark among
Yeah.
our cohort of clinics and practices, so that they can look at their care relative to others.
Hmm.
We did a bit of that in the early days of EpiSoft, but we
Yeah.
haven't done much more recently because we're kind of busy working on this change request and that change request. So you've
Yeah.
got to actually, if you do want to achieve bigger vision, you've got to resource it appropriately and keep it resourced outside of your day-to-day operations of your business. And so we haven't done that as effectively as I'd like to, but the idea would be, it wouldn't be anything we'd want to bring other, customers of non-EpiSoft customers into at the broader macro level. But there's been a couple of ideas I've had about doing just certain components of evidence in practice that
Yeah.
could that multiple vendors, not just us, but other vendors and other customers of other vendors it could be of interest to them. I haven't
Yeah.
until I make that a reality. I don't really want to talk about it further, but
No, of course. No.
um,
Yeah,
I
and like
won't
that's
get
me.
far.
Yeah, yeah, yeah. Just trying to get a better
Yeah,
understanding.
I'd like to start a little piece of it that's non-controversial and will benefit
Yeah.
everybody. Um,
Yeah.
so that's the first part of making it broader than the EpiSoft platform.
Yeah, but I mean, of course, it makes sense that it's people that EpiSoft is working with directly, where the data is. We most clearly understand how to use it in beneficial ways, and
Yeah,
that continuing the challenge of trying to just improve outcomes, improve our knowledge, improve clinical knowledge, right? And it actually, I feel like, just personally, that I feel like it can seem obvious, like evidence in practice, but I also feel like it's not. And
mm.
because also at HIC, and some of the things we listened to and conversations we had, it's a bit surprising how many times evidence is not actually a part of decisions that get made, and systems that get put in place, workflows that get put in place, where I think it's such an important thing to just remind everyone we have to come back to, is just like the practicality of evidence, and
Yeah.
making sure that we can point to all this, and this for why we're doing things. And yeah, and so in my opinion, I feel like
Doesn't
it's a
even have
great.
to be
Yeah.
clinical evidence. It could be just, I want to change this in the software system,
Hmm.
and the evidence I have to say this is a good reason to do this is this.
Yeah.
Like, so there's so many times people say, can we change this, without really
Hmm.
thinking about having a rationale, just having a rationale for what you want to do, how it would improve your work, or how it would improve, patient use of a platform, whatever the case may be. It always
Hmm.
comes back to saying, yeah, ideally why, why, of course, but how can we prove that if we do it and improve it, that we
Yeah.
have? Yeah, so we're not
Yeah.
very good at capturing a baseline to say this is how bad something is right now, and
Yeah.
this is how great it was after. You never have that first
Mm.
data point to know what you've changed, and it's important to do that when you can.
Yeah. Yeah. And so there's our message for everybody, is just the evidence and data really matters.
Yes,
Please.
excellent.
um, you know, um, with all the things we've been talking about, Jenny, what do you feel like it actually looks like when a hospital is getting all of these things right? Not just the software, although of course, that's a huge component, but
Mm,
also just the culture, the workflows as well.
mm. I think the key thing where things have worked really well is a skilled health informatician, however you like to define that person. Doesn't have to be, somebody with great in-depth IT skills, or but it needs to be someone that can translate the challenges faced by end users into something that IT people can understand and deliver on, and make sure it gets delivered to, to that vision. And
Hmm.
where I've found things not working so right is when they have key resources in that area that leave and aren't replaced, and they expect things to go on as well as they used to, and or they don't resource that skill in the first place, or undervalue it. So if that gap between frontline staff and IT isn't bridged effectively, that's when things don't go right.
Okay. Okay. And so, I guess, do you think the experience starts even earlier than most people think, like well before the patients even arrive? Oh, sorry, my cat's running amok.
Oh, um, the patient experience, you mean, or
Just in terms of everything running smoothly, making sure that all the kind of right communication and
mm, mm.
cooperation is happening, I suppose.
Yeah, definitely. Well, I mean, that's kind of the vision between in our EpiMe pre-admission platform was
Right.
that the first communication between patient and hospital is, and this is private, so I'm talking about anyway.
Yeah.
Doctor makes a decision to refer a patient to hospital or book a patient into hospital. And then the patient's first experience with the hospital is, what do I have to do to get ready for that? And, back in the day, it was all paper, so they had to fill in 10 pages of forms.
Hmm.
Now it's about 10 pages or more of online forms.
Yeah.
So it definitely starts before somebody gets there. And yeah, that whole process of thinking about the airlines and the check-in in advance and what you have to do to get ready, all of that applies to the health sector as well,
Yeah.
and has been streamlined to a much greater degree than it used to be. I
Hmm.
worked in a hospital looking at the whole flow of paperwork coming in for different
Mm.
bookings, different, and there was about 12 different areas that were collecting what essentially was an inpatient booking, not even
Mm.
outpatients. These were
Wow.
inpatient
Yeah.
bookings. 12 different areas involved, and nothing was streamlined. And so one of my first jobs was to streamline it, even though it was paper based. It was all about process improvement and centralizing work effort,
Yeah.
and stopping and standardizing work effort.
Hmm.
Um, and so it's not always an IT solution that
Yeah.
is what's needed to start with. If you put IT solutions into process flows that are really broken or not optimized, then you can end up putting lipstick on a pig. So you do have to, look at your process at the same time
Uh-huh.
as you're looking at your software and make sure that they align and that, yeah, you're not continuing with inefficient processes after you've implemented an IT system, because you
Yeah.
won't get the gains out of it that you expect. So it's always
Yeah.
best to look at that holistically and do, process improvement at the same
Hmm.
time as technology implementation. Very important.
Yeah, that's actually a conversation that Edward and I have had a couple times too, just about, with all of the kind of buzz around AI, and some people are so gung ho about it. And it's kind of, it's easy to miss how much benefit can come to a service from what you're talking about, getting the workflows right, this kind of organizing on a simpler, more human level before we even start to think about, all this technological automation. And that, again, it seemed like a big kind of talking point at HIC, just how I think a lot of the industry was kind of getting swept up and almost putting the cart before the horse,
Mhm.
and everyone's kind of taking a pause and a step back and just kind of rethinking, well, hold on, how do we actually take the most effective steps forward,
Mm,
for everybody, the
mm.
clinicians, for the patients, for everybody involved. And so
Yeah, huge
it's wonderful.
opportunities in AI, but it has to be part of that broader picture of process improvement, technology, standard technology, for want of a better word,
Yeah.
plus AI. So the three components working together, because, as you
Yeah.
say, it won't be lipstick on a pig. It'll be something else on a pig.
To the gold earrings, gold ear.
Right, something very expensive.
I know, or just a full-on robot. We'll put the robot on the pig. No.
Yeah. Right.
Okay. Yeah. Well, so Jenny, I guess to kind of wrap up our session today, if we're looking forward, thinking about the future, and I mean, maybe, the answer to this has already kind of come up. We have covered a pretty wide range, but if there's anything about this you haven't said, now is the time. No.
Sure.
um, what would you most want to see change in cancer care in Australia, let's say over the next 10 years, let's kind of limit it there. And what role does software have to play in that?
Oh, sure. Okay. Well, I suppose in the immediate, like in the clinical space, obviously there's very exciting innovations in cancer screening where you can screen for cancers with less invasive screening techniques that then deliver on potentially the same benefits as invasive procedures. So that's exciting. And the other ones, obviously, the immunotherapy range of immunotherapy treatments that are coming through the pipeline and improving survival rates of cancers where the survival rate was not great before. So prognosis of patients with cancer is improving from those new treatments. So what role does software play? Coming a bit close to home for us, though, literally. So this is more about how is treatment delivered and where is
Mhm.
treatment delivered, and
Yeah.
what we have a role to play in ensuring that care providers in rural and remote regions have access to quality software systems to support the care of their patients. And that means that people don't have to travel, hundreds of kilometres to get their cancer treatments. They can have it
Mhm.
closer to home, and literally they can have it in the home these days. So there is a growing group of care providers that offer chemotherapy and other infusion treatments in patients' homes. And so we're delighted to have been at the forefront of that trend too and
Yeah.
supporting care providers in that space.
Yeah.
And so, sort of talking about those two very different things separately is, I guess, the gap that we can help bridge is with that evidence in practice sort of concept of saying, okay, if patients are on these new innovative treatments, they might be on a clinical trial where they've got the data flowing through EpiSoft, which happens. And then, yeah, if we can actually get that research publication cycle happening more quickly and effectively and efficiently, then yeah, that's, I think, the exciting part of it, which I think is achievable in a decade because it's already underway. Um,
Mhm.
so it's really just making it a bit more ubiquitous. As they say, the future's already here. It's just not evenly distributed. So I'd like to see a more
Yeah.
even distribution of the future. Yeah.
Yeah. Okay. Yeah. No, I mean, I think that makes a lot of sense. And so, kind of what I'm hearing is basically still patient centric, just trying to make sure that the top quality treatments can get to the patients who need it as kind of conveniently and
Mm,
simply as possible, and continuing to kind of, I guess, improve the possibilities for patients with, I suppose, more rare kinds of
mm,
cancer, or treatments that are less common,
mhm.
and just continuing to just elevate the care across the board.
Yeah, and I should just probably mention that, I mean, ideally, I'd like to see, I'm not sure if it's going to happen, is just
Mhm.
ensuring that patients getting innovative treatments off indication, meaning um, care providers are experimenting outside of the PBS arrangements, pharmaceutical benefit scheme, and
Mhm.
ensuring that some of that data can get back to the decision makers in the PBS to try and get
Yeah.
those treatments subsidised more
Yeah.
quickly and more effectively. That would be that's yeah. There's
Yeah.
innovations that can happen in that space that I think
Yeah.
will benefit patients with cancer.
Yeah, and that's fantastic. And yet another step in our the evidence and practice
Mm,
initiative.
indeed.
And that's awesome. Well, Jenny, I mean, is there anything else that you'd like to say about anything, or how are
No,
you feeling?
no, I'm good.
Yeah.
Thanks,
All right.
talking to you, Jeremy, and thank you.
Yeah, no, thank you, Jenny. It's been wonderful speaking with you, and just kind of picking your brain on some of these topics, and thank you for your time.
Pleasure.
And yeah, thank you to anybody who has listened, who's tuned in. We hope there's been something of benefit, or I'm feeling inspired. Maybe you're feeling inspired as well, by this chat. But thank you for listening to Patient by Design with EpiSoft. I'm Jeremy. I work in the business development, and this is our wonderful CEO.
Thank you, Jeremy.
Yeah, of course. Yeah, thank you, Jenny. And have a lovely day to you. Have a lovely day to anybody listening, and we'll see you next time. Thank
All
you.
right, lovely talking with you. Bye bye.